Hello and welcome to lectures on cardiac morphology and congenital heart disease. This video is on left ventricular outflow obstruction, including hypertrophic cardiomyopathy, subaortic and aortic stenosis, and hypoplastic left heart syndrome. So we have a nice collection of specimens for you here. We'll start with the critical aortic stenosis, then an interruption of aortic arch, followed by a specimen with coarctation of the aorta and left ventricular ischemia, and a hypoplastic left heart syndrome. And then we will show a post-operative specimen of Norwood operation and hypoplastic left heart syndrome. And finally, a right ventricle to pulmonary artery conduit in patient with hypoplastic left heart syndrome. So let's start. Okay, so let's take a look at this specimen here. If we open the left ventricle, please note, let me get the specimen closer to you and look at this aortic valve. When we describe the aortic valve, we describe the valve in terms of leaflets and commissures. In this valve, we don't actually see commissures. We see this separation of these two leaflets that goes all the way to the annulus, which in fact is caused by balloon dilatation of this unicuspid valve. So this is actually a unicuspid valve with a unicommissure that had a balloon valvuloplasty that caused this tear of this valve, which is a way of treating this lesion. And that can also be done surgically to perform the same result. You can see that the leaflets are dysplastic and thickened as well. Now, another result of this aortic valve stenosis is what we see up in the aortic ascending aorta posteriorly. Look at the dilatation of the ascending aorta from the posterior aspect, and this is a post-stenotic dilatation caused by the stenosis of the valve, with the jet through the valve hitting the posterior wall of the aorta, causing this significant dilation, as you can see here. And that's this is one of the hallmarks of this disease. Now, if we look at the left ventricle, and because the left ventricle is exposed to very high pressure, the coronary flow is compromised, especially to the most dynamic part of the ventricle, which is this lower part here, which is the inferior part of the ventricle. And this compromising coronary flow can cause two things. Look at this thickness at the apical part of the septum, and look how the area is thinner down towards the apex, and that's because of the coronary compromise. Also note the endocardial fibroelastosis that covers the endocardium. That's also as a result of the coronary perfusion. Now look at this mitral valve. The mitral valve is smaller than expected to the size of the left ventricle. If you look at the LV, it's either the left ventricle is dilated or the mitral valve is small, or both. And if we look at the attachment of these mitral valves, we see that the attachments are shortened and abnormal. And this is, in fact, a parachute mitral valve. As you can see, it looks like a parachute that is tethered by two sets of attachments that are very close to each other. And that can cause an inflow compromise to the left ventricle, or restriction of inflow to the left ventricle, which further complicate the disease, and that sometimes also can be treated interventionally by balloon valvuloplasty. So this patient has two obstructive lesions on the left side, mitral and aortic. This is another example that is similar to the previous one, where we have a monocuspid unicommissural aortic valve, but this valve was treated surgically. So there was a surgical approach here to do valvuloplasty and open it up. Another common feature to the previous case is the ischemia that occurred in that left ventricle. So look at the prominent endocardial fibroelastosis that you can see here. That is a result of fetal ischemia of the endocardium, resulting in this shiny white fibrosis of the endocardium. Um, we also look at the mitral valve. It's also small for that ventricle, as you can see, and the chordal attachments also are hypoplastic. In some of these cases, we will have a decreased outflow from the left ventricle through the obstruction, and that will cause hypoplasia of the transverse arch, because some of the venous return from the lung goes from the left atria to the right atria, and then mix with the venous systemic return to the pulmonary artery, and we will have a persistent large ductus arteriosus that supplies the descending aorta, which is right here. So the transverse arch has less perfusion and becomes hypoplastic, whereas the ascending aorta receiving part of the cardiac output and supplies the head vessels, head and neck vessels, as we see right here. Next is an example of a post-operative interrupted aortic arch. Here we see the area of what used to be an interruption that was surgically repaired. If you pay attention here to this area, this is the neo-aortic area, which was supplied by a duct coming from here to there. So the ductus arteriosus was supplying the descending aorta in this area right there, where it was dissected, and then the descending aorta cannulated directly to the ascending aorta, as you can see. This is the pulmonary trunk right here, and if we look from a cranial view, this is the left pulmonary artery, and that's the right pulmonary artery, and this is where the ductus origin was, supplying this area. So you can see the relative size of the duct compared to the descending aorta, almost similar in size. However, in this case, although there was a ventricular septal defect, this defect was not very helpful in supplying more blood to the aorta due to the hypertrophy of the left ventricle. As you can see, there was severe ventricular hypertrophy that caused this subendocardial ischemia, as you can see, the discoloration. So this lesion affects the myocardium in a very severe way, causing hypertrophy and ischemia. And in this case, obviously, the patient did not survive. So another example of interrupted aortic arch. In this next example, we see a different variation. If we look at the external surface of the heart, we see that the heart shape is different from the previous specimens. This is the right ventricle right here, and we expect the left ventricle to be right there. However, we look at the apex and the left ventricle, we see that the left ventricle is elongated and dilated, and we can see this elongation toward the apex right there. We see the difference in thickness between the basal part of the left ventricle and the apical part of the left ventricle, which is much thinner, and this is due to the ischemia and the hypoperfusion. Also note the subendocardial ischemia and the discoloration that is there, as we saw previously in the previous specimens. Also in this specimen, we see that the ascending aorta is slightly hypoplastic, but more so the isthmus. If we look at the isthmus, look at the size of the pulmonary artery compared to the size of the ascending aorta here. It is much larger, and the isthmus area, which is very hypoplastic. So we have several challenging issues in this patient when we consider repairing this patient and providing systemic blood flow to the rest of the body with this kind of situation. So the anatomy and of the aortic valve is very critical, of course, here, and also the anatomy of the mitral valve. If you look at the mitral valve, it's also small, and it is a parachute in shape, as we have seen previously. Here in hypoplastic left heart syndrome, the left atrium, mitral valve, left ventricle, and aorta are all hypoplastic. So if we look here, we see the pulmonary artery, very large here, and next to it, this thread-like structure, which is the hypoplastic ascending aorta. And here, we see that continues to the descending aorta through the aortic arch, and that's the patent ductus arteriosus right there. If we look at it from the side to show the posterior aspect, we see this is the left pulmonary artery going to the left lung, and here we see the right pulmonary artery going to the right lung, and that's the ascending aorta. And if we pay attention, we see the right coronary artery arising from the aorta right here. So this structure becomes very important and crucial, as a matter of fact, in perfusing the heart and supplying the coronary artery to the ventricles, both of them. So the blood comes from the right ventricle to the pulmonary artery to the transverse arch in a retrograde fashion into the ascending aorta, perfusing the coronary arteries, especially that the aortic valve is atretic, and that will sustain the coronary perfusion to the heart. So let's look at these calipers of these vessels again to understand this physiology. So this is the pulmonary artery, which is very large. Blood goes through that pulmonary artery, supplying the descending aorta through this large patent ductus arteriosus. Some of the blood will go into the transverse arch in retrograde and supply the head and neck vessels, as you can see here. And some of this blood will come down the ascending aorta and supply the coronary arteries. So the ascending aorta in this situation serves as a common coronary artery stump. Now, the systemic circulation and the pulmonary circulation are competitive in this situation, so that if there's too much pulmonary flow, the systemic circulation will be compromised, and if there is too much systemic flow, the pulmonary circulation will be compromised and suffer. So it's very important to consider this if in management, if the patient presented to the emergency room, for example, because of cyanosis, and the emergency room doctors gave too much oxygen, and the baby had pulmonary arterial dilation because of that, and too much pulmonary flow, that will decrease the flow into the systemic circulation, although the baby may become pinker and the doctors may think that he is actually better. So where in fact we will be harming the child. So the balance between the systemic and the pulmonary circulation is crucial in this situation, and in most of the ductal dependent lesions, as you can see, the ductus is the source of blood to the systemic circulation, and look at the size of this duct. So the balance between that duct and the lung circulation becomes crucial in this situation. As you can see, the ductus is actually the continuation of the pulmonary artery into the descending aorta. Now, if we open the right ventricle, which is in this case is a very large and dilated ventricle, but it is the right ventricle in morphology, as we can see here. We look to the left of this ventricle and we see the left ventricle, which is this, a slit-like cavity that is the left ventricle located at the left lateral aspect of the heart. Now, and if we look externally from the inferior surface of the heart, we can see the posterior descending coronary artery, the left posterior descending, and the left anterior descending, both of them demarcating the left ventricle. You can see how small the space of the left ventricle, and if we open it, this is it. Just a slit-like cavity that has no mitral valve and no aortic valve, as a matter of fact, which is very common in this situation. In hypoplastic left heart syndrome, you have mitral atresia and aortic atresia. So this is the left ventricle right there. Now, in this case, the flow that is returning from the lungs to the left atrium here goes through an atrial septal defect into the right atrium. Now, the next specimen is a post-operative specimen of hypoplastic left heart syndrome. So we will discuss here the principle behind this palliative procedure, which is the Norwood operation. So the Norwood operation is the first stage in a staged operations, aiming in the end to separate the pulmonary flow from the systemic flow. So if we look at the right ventricle here, the right ventricle will serve as the systemic ventricle in this operation. So it will have to be connected through this material, synthetic material or natural, and that's one of the variations, into the descending aorta to provide flow to the systemic to the system, and also in retrograde to the coronary arteries through this ascending aorta. So the blood will flow back into the ascending aorta down to the coronaries and down the descending aorta to the rest of the body. Now, in this operation, the right ventricle will be separated from the pulmonary artery, obviously. So this will be disconnected. This is the pulmonary artery, and it's disconnected from the right ventricle. So in order to supply blood to both lungs, another source of blood should be established, and in this case, it is a blay-lactasing shunt here from the right innominate or right subclavian down to the pulmonary artery branches or the pulmonary artery confluence, or in this case to the right pulmonary artery. The length and the diameter of this shunt is very important to provide adequate flow, but in a controlled manner, and providing a low pressure flow to both lungs to protect them in the long run and help prepare for the next operation, which is cavopulmonary anastomosis, and finally the Fontan operation. Again, this is the principle of the Norwood operation. There has been many variations, whether in the shunt or the main anastomosis in the surgery, but the principle remains the same, however. So in this next specimen, we will look at another variation of the Norwood operation. In this case, it is called the Norwood operation with the Sano shunt. So the same principle applies, is that the aim is to separate the systemic circulation from the pulmonary circulation. And if we look here at the pulmonary artery branches, the pulmonary artery branches were separated from the main pulmonary trunk and dissected here in a stump that I'm holding here. And the main, the right ventricle here is connected directly into the ascending anastomosis with the ascending aorta to provide systemic blood to the ascending aorta, head vessels, and the coronary artery to perfuse the right ventricle, which is now the systemic ventricle. And the pulmonary flow, in this case, is provided not by a BT shunt as we saw in the previous case that goes from in this fashion, but by this graft that connects the pulmonary stump to the right ventricle, which is the systemic ventricle. This graft will provide the flow in a controlled fashion into the lung, similar to the BT shunt that we saw in the previous example. Now, we need to note that there are advantages and disadvantages to every operation. So it all depends on the institutional policy that is established for this operation, and also individually for each patient. Now, let's take a look at the heart and the anatomy. So if we remove or pull this pericardium here that was covering the heart in this way, we can open and see. Let's first put the heart together. I want to show you again the left ventricle size as we saw in previous specimens. So if we put the inferior wall of the heart together, we can see the coronary arteries, the left anterior descending and the left posterior descending coronary arteries, demarcating the left ventricle in between them. This is the left anterior and the other was the left posterior. And this area in between them is the left ventricle. So if we dissect in between, we will open into the left ventricle, which is
also very small and hypoplastic in this case. As a matter of fact, we can only see this dark line which represent a clot that filled the left ventricular cavity, as you can see. So this slit that is filled with this clot is actually the left ventricle right there. And this is the right ventricle, and this is the tricuspid valve. So in this case, the blood returns from the left atrium into the right atrium through an atrial septal defect, and from the right atrium through this tricuspid valve into the right ventricle, and then goes up the newly anastomosed Norwood anastomosis into the ascending aorta and the head and neck vessels, and to the lung through the Sano shunt. So that concludes our presentation today, and we'll see you in our next video. Thank you for your attention.